Stop treating every depressed patient with just a standard SSRI and hoping for the best. If you want to stop guessing and start prescribing like an expert, you need to master the 3 core clinical variables that actually dictate major depressive disorder management. Let's start with the current episode. The severity of the symptoms is your first clue. Mild cases might just need active monitoring or exercise, but moderate to severe cases demand pharmacotherapy, structured psychotherapy, or both. Here is the most critical part: safety and risk assessment. If your patient is highly suicidal or refusing to eat and drink, that is an immediate indication for hospitalization and electroconvulsive therapy. You also need to actively look for clinical specifiers. Psychotic features mean you must use an antipsychotic and antidepressant combination. If they have catatonic features, benzodiazepines are your first line. And if they show mixed features like subsyndromal mania, be very careful because standard antidepressant monotherapy might just make things worse and increase suicide risk. Next, we look at the temporal course and demographics. Age changes everything. For children, fluoxetine is the only recommended SSRI, while in the elderly, you must start low, go slow, and closely monitor for falls and hyponatremia. You also have to consider gender and reproductive status to minimize teratogenic risks during pregnancy or to time medications for premenstrual issues. But do not forget the past illness course. If your patient has had 3 or more lifetime episodes, you are looking at long-term or even lifelong maintenance therapy. A massive high-yield point for your clinical assessments is that past treatment response in the patient or a first-degree relative is the strongest predictor of future efficacy. Always screen for a family history of bipolar disorder to avoid an antidepressant-induced manic switch. Finally, you cannot ignore comorbidities. Physical conditions completely alter your drug choice. Avoid tricyclics in cardiac disease and use sertraline instead. Treat underlying endocrine issues first and choose weight-neutral agents for patients with metabolic syndrome. For psychiatric comorbidities, if substance use is in the picture, wait for a 2 to 4 week abstinence period before confirming a primary depression diagnosis. If they have borderline personality disorder, prioritize dialectical behavior therapy over biological escalation. And never forget psychosocial variables. A lack of social support might mean they need inpatient care, and respecting your patient's preference between medication and therapy will drastically improve their adherence. Master these 3 domains, and your clinical decision-making will be unmatched.